Hi, everyone. Good morning. My name is Alex Castillo-Smith, and I work with the New Mexico Human Services Department. Thank you for joining us for this COVID-19 Day 164 press update. We have a lot of topics to cover today, and I'm pleased that we're joined by the New Mexico Human Services Department Secretary, Dr. David Scrase, as well as a special guest from the New Mexico Department of Health, Acting State Epidemiologist, Dr. Chad Smelser. They'll run through the materials today, send the web link to the recording of this press update later today, as well as the presentation itself. And I think this questions today will be primarily reserved for members of the media. If you have a question, we ask that you ask it pertaining to the section of the presentation that we're in. You can either raise your hand, let me know you have a question, I'll unmute you, or you can type it into the chat and I can ask the question on your behalf. And all other questions will be covered at the end of the presentation. We'll have time for an open question and answer period. I think with that, I will mute myself and turn it over to you, David.
Thank you very much, Alex. Thanks to the members of the press for being present with us today, and in particular for keeping us on our toes over the past week. As I've said before, I love getting math questions, and we've had a fair number of them. We're going to start today with our special guest, Dr. Chad Smelser, our lead epidemiologist for the state, who's been working tirelessly, very long hours, particularly in July and early August on controlling the pandemic. I'm going to give you a few select science and media updates with a focus on pediatrics, with some help from some data from Los Alamos National Labs, a quick update from the CDC on vaccine development with some of the dates. Well, not really. Some of the date ranges that you all have been asking about. Talk a little bit about new information coming out today from the MAT on different kinds of testing and ways of expanding our testing. We're going to directly answer a question that was in the news this week about different ways of reporting 7-day rolling average tests and cases. And then we'll get to the really great news, which is the public health reopening gating criteria for New Mexico, and then some other brief comments. If you do have questions about these areas, as Alex said, please try to put those questions in the context of those areas. We reserve the right, if we know there's more information that sheds light on your question, to maybe defer it to the next question and answer break. But we're trying to do this in a way that you can have your questions be contemporaneous. And then if I need to, I can go back to a slide that you have a question about more quickly. And so with that, I'm going to turn over to Dr. Smelser, who is going to walk you through a representative sample of the sort of data that his department produces and that we actually review on a very, very regular basis. Chad.
Thank you, Secretary Scrase, and thank you to members of the media and other folks who are on this call that we're able to give you this update. I hope you find it informative. I am the acting state epidemiologist. I took over after the retirement of Dr. Michael Landon in mid-July. In that role, I've been responsible for the epi reports and things that come out each day, as well as combining our data sets that we gather into usable data, and we hope to present some of that for you today. And then stand for questions so we can answer any questions that you have, or if there are new ideas, we're always welcome to hear those. We find it helpful the more discussion that we have. So starting off, I just wanted to give a little bit of perspective about COVID-19. I may refer to COVID-19 during this, and that's generally the disease, so the spectrum of illness in people. The virus is SARS-CoV-2, and so you might hear that come out of my mouth when I'm talking specifically about the virus. But just a perspective on COVID-19, and these numbers are all estimates. They're gathered from CDC, from the World Health Organization, for the most part. And it's the table has a comparison of COVID-19 to other respiratory pathogens. And then the columns you see are how infectious is the agent, what is the case fatality rate, and the deaths that occur daily worldwide, which of course is varying for COVID quite a bit. But so these are estimates and generalizations. But if you look, COVID-19 in comparison to Spanish flu, which was a 1918-1919 pandemic, H1N1 2009 pandemic, and tuberculosis in the table, there's a range for infectiousness from 1.5 to 3.5. That's because this is new. We're learning as it goes, and it's varied throughout the world in terms of what's been reported. But as you can see, the upper end of that 3.5 is higher than all of those other pathogens. In the case fatality rate, which is the number of fatal cases over the total number of cases, you can see again the range has been pretty wide for COVID-19, but the upper end of that range is higher than the other three. Then deaths per day worldwide. COVID is also at this point, above 3,000. We expect as more and more people are, infected and there becomes a baseline over time, that'll come down. But in perspective, we have tuberculosis deaths in that range each day throughout the world. I will note at the bottom of the table that there are some other infectious diseases, just for reference, that have over 2,000 deaths worldwide per day. HIV, malaria, hepatitis B are some examples. So the main takeaway from this is, like I said, perspective and just the idea that COVID-19 is an extremely serious disease, and that this pandemic has, obviously wreaked havoc on our world, our state, and our local communities. Next slide, please. So how are we doing in the state of New Mexico? So currently, and this was as of the August 18th, so of this week, we have the 36th highest prevalence in the United States, which is good. So we are, at the bottom of the table, or towards the bottom of the table, and that means overall we have less viral burden in our state than other places do. This table is, that graph was, per 100,000 prevalence rates. Next slide. This is what we call an epidemic curve. So it's over time. It's from the beginning of the pandemic, and the gray bar, the big gray bar at the right side of the graph, is the current time period, which we're still updating cases there, so we can't interpret that data. The blue bars are the daily case counts by specimen collection date, and the black line, the black dashed line, is a rolling 7-day average. We produce this a couple of days a week. Monday was the last day that we produced this, and this is good news. So this is statewide. You can see we had a steady rise to our first peak in the beginning of May. Thank you for the pointer. We had a bit of a plateau with a bit of a rise in the middle of it, a small bump, and then we had towards the middle of June a steady increase to our last peak, which ended around the 26th, 25th of July, and we've seen a steady decline. So the steady decline is really good news. We, of course, want to keep that progress going, and we are appreciative of all those people out there wearing masks and maintaining their social distance to keep that low. The next set of slides are going to be broken down by New Mexico region. So this is the metro region, which essentially is focused around Bernalillo County and the counties surrounding it. As you can see, it matches in comparison to the previous graph, it matches the statewide, and that's because our largest population drives a lot of the statewide data that we have because of the magnitude of the population. And you can see over to the right, we've had a steady decline that mimics the statewide graph that I showed you previously. Next slide. This is the Northeast region, and the Northeast region did not suffer as high of a peak or as great a magnitude of cases early in the pandemic, and then beginning in the middle of June saw that same rise that the rest of the state saw, with some particular days with large case counts, which most of those, I'll describe those a bit later in some other graphs, but center around correctional or detention facility outbreaks, where you have a large number of people and they test it one day, and so you get a lot of results all at once. Anyways, we've seen a similar decline in the Northeast region, which we also think is a good thing. This is the Northwest region. Of course, this region, as you all know, was mostly centered around McKinley and San Juan counties. There was a lot of activity early on and a very big peak that also incorporated the numbers from the Navajo Nation. And since that peak, we've seen a relative steady decline with a slight uptick again in June, and then further steady decline until present day. Those orange bars are, again, detention center outbreaks in the area that occurred, and they are not included in that rolling 7-day average, which is why you don't see a bump associated with those orange bars. The next slide, please. This is our Southwest region. So Doñana County has the largest population, but it stretches along the border as well as over to our border with Arizona. And as you can see, it had low activity early on. Again, an increase in June. It plateaued maybe for a little bit longer than the state, but has seen in recent weeks a steady decline. Again, the orange bars were outbreaks associated with correctional facilities in that area, and they're not in the 7-day rolling average. Next slide. This is the Southeast region. I would say at this time, this is our most problematic region in terms of the epidemic curve. It had low activity at the start, had increases in early June, and has unfortunately at this point maintained a plateau as opposed to reaching a true peak and then descending down. We are hoping in the near future it will be going down, but this is also not that surprising because of the heavy influence of Texas and the Southeast region sharing, essentially all of its border with Texas. And so Texas, I believe, is the next slide, just to give you some perspective. And you can see up in the upper left corner that New Mexico is the black area, and then the state of Texas. Most of Texas activity is, again, where its big population bases are on the eastern and southern parts of the state. However, there's a significant activity in the El Paso region, Midland, Lubbock, and Amarillo, which all influence New Mexico. There's lots of travel between those businesses, personal travel, families, etc. So we are following what's going on in the states around us, not just Texas. Thankfully, Colorado, Arizona, case counts and their rolling averages are going down like we're seeing. Texas has reached somewhat of a plateau. So our Southeast region is mimicking the Texas plateau. Next slide, please. One of the things people ask us commonly are, okay, what's associated with cases? This is a graph with multiple lines on it that are colored by different sorts of potential exposures or activities that people have undertaken before in the 14 days before they become ill. And as you can see, the top lines on this graph are travel. This is travel anywhere, so it's travel in the state as well as travel out of the state. But travel or moving around is a significant factor in some of our cases. The other one that you see in red that has gone up recently was attending other gatherings. This is a catch-all group of people getting together. We particularly see increases in this around times when people are getting their families together or going to other social functions. I don't know, the other lines on there have all been decreasing, which is good. Their overall trend is a decrease, but we do also monitor, any increases. And you can see there was a short increase on the, I don't know what color everybody is seeing on that. It's kind of a pink color to me, but it's places of worship. But we've seen that coming down in recent days. Again, the gray area, the data is too new and still being updated to make full conclusions. Thank you. Next slide. This is our prevalence per 100,000 of the population, separated by those regions of the state, with New Mexico overall prevalence and in the red on the right-hand side. The left-hand side of this are new cases in the last 7 days, up until August 3rd, and the other side, August 3rd, excuse me, and the right-hand side are new cases in the last 7 days, August 16th. Not surprising if you look at our state epi curves, things are coming down in all regions, but the Southeast, and you can see in the middle of the graph, the Southeast bar has been the highest in terms of prevalence per 100,000 in the last 2 weeks. Otherwise, the other bars, I'm sorry to go slow there. The other bars in that slide haven't changed that much, so they're relatively stable. The next slide, please. This is about hospitalizations, and it's a bit complicated, but it's not too hard to follow. So it's over time again. The left-hand axis is the number of hospitalized cases, and those are the bars. And the bars have two colors. The orange color are no ventilator use or mechanical ventilation. Generally, that's ICU beds. And then the turquoise color are people using ventilators. And that blue line that you see coming across the graph are the percent of patients who are on ventilators, and that's on the right-hand vertical axis. So the good news here is you see the two peaks in hospitalized cases earlier when we were having our highest peak at the start, and then again another peak with our latest from that started in mid-June, but our peak for hospitalizations are a little bit later. That's typical. We certainly get a delay in people. Once they get ill, it takes them time to get more and more ill that they might need to be in a hospital. The other good news on this graph is our ventilator use, or the percentage was pretty high at the start of this, largely because it was the first cases coming in. We were detecting them mostly in the hospital. They were an older population with significant comorbidities, and before some of the prevention messages and orders were in place, but it's come steadily down, and it's maintained itself at about 20% over towards the right in the more recent data. So that's good. Next slide, please. So what about hospitalizations by race and ethnicity? This graph, the lines are different race ethnicities and their hospitalization numbers each week over time. And as you can see, there's a peak in the middle. That was our American Indian, Alaska Native in the red, and that corresponds well with the peak that was occurring early in the pandemic in the state, which was largely focused around counties where American Indian folks reside. Recently, over towards the right in the green line, as well as the, I guess that's violet or purple color, we've seen increases in our Hispanic and Latino groups, and in the white non-Hispanic group. Again, the shaded area, we can't make conclusions. We see that the Hispanic may be going down, and the white non-Hispanics may be going up. We'll need to track that over time. But this does correspond to what we've seen in terms of activity around the state. So instead of the activity being all in areas where American Indian, it's transitioned to other parts of the state, and other race and ethnicities are being impacted. Next slide, please. This slide is on deaths. Again, these are deaths by number of deaths by week, and you can see that there was a peak early in the pandemic, and thankfully we have not gone back up to those levels. We went down until July, where we started seeing small increases and then further increases towards the end of July. And recent week, we've been down, and we hope to maintain that trend. Again, this is usually delayed from the specimen, the epidemic curve and the specimen collection date curves that I showed earlier, because there's a disease process before somebody expires from the disease. And then some delay in us getting the data in the system and counting the death certificates appropriately. Next slide, please. So just to let you know that our mortality with age has really remained unchanged. This is throughout the pandemic in the state of New Mexico, that as you get older, and as well as you probably accumulate some more comorbidities or other diseases that contribute to severe outcomes, you're more likely to die from COVID disease. Next slide, please. We've broken these data down by region. These are case fatality rates by region. And on the right-hand side, you can see the US case fatality rate, which is around 3.1, and New Mexico's, which is 4.1%. So at present time, we're higher than the US. And you can see on the blue bars toward the left by region in the state that we've seen the highest case fatality rates in those in the Northwest. And this has largely been due to American Indian population, as well as people with comorbidities. And so we continue to track that and work with those populations directly as much as possible. And we're also looking at reasons why New Mexico is a little bit higher than the United States. I imagine over time we may level out. I think there are lots of delays in case fatality rate reporting, as well as just death certificate data. In New Mexico, we have a pretty rapid, compared to the rest of the country, centralized system. We don't rely on coroners and counties and that sort of thing. So we get our data a little quicker. But what I hope actually happens is that our data comes down a bit or normalizes with the US over time. Next slide. This is an interesting slide. We don't just look at your age, your race and ethnicity, or your comorbidities. We look at other factors that contribute to the cases that occur in our state. And so this is a socioeconomic status slide. It's the COVID-19 cases per 100,000 population, and it's by census tract poverty rate based on the national poverty rate. Over to the left is less than 5% poverty in that census tract. Progressing to the right is greater than, it's 40% or more poverty level, national poverty level in that census tract. And obviously you can see the trend line is with increasing poverty levels, you have increasing rates of COVID. The natural question is, why is that? I think it has to do with a lot of factors. One of them being, we also see the same trend for comorbidities. So those people are likely to get sicker, more likely to be tested. We also see a higher density in houses. So more people in a single house with less ability to isolate from one another. And then there also may be a factor of you need to get out, and because of your salaries or because of the amount of money you make, you may need to get out more to get things that you need or to continue working. Next slide, please. Just to bring this, wrap this up from the status updates, in general, we gave you a little bit of flavor about New Mexico compared to the other states, both around us and the US. And in general, New Mexico is doing well on most of our metrics compared to other states. I didn't really bring this up, but in particular, we are very good at testing. We have one of the highest top 5 testing rates in the country, and that allows us to really know what's going on in our populations. Case counts in the state overall have been declining, with one note that we have a plateau in the southeast region of the state that we need to keep an eye on. Hospitalizations, we did have a period of increase in July. It corresponded somewhat with our increase in cases overall, and it's been decreasing along with our decreasing cases, which is good. Deaths, it's the same story. Had a little bit of a 2-week increase recently, but last week was a good week for a decrease, and we anticipate if our cases stay low that we'll continue in that range. And then just to note from that last slide that poverty is clearly a significant factor in contracting the SARS-CoV virus or the COVID-19 disease in New Mexico.
So Alex, I think we'll stop here for a minute, understanding that we're going to be going into depth more on the gating criteria at the end, and also talk about the details methodology for measuring 7-day rolling average case counts. Are there questions right now for Dr. Smelser regarding the epidemiology? And thanks very much for the great presentation, Chad.
We have one question from Kevin Wilson. I'm going to unmute him so that he can ask. And just for the members of the media, when you ask your question, please identify yourself by name and media outlet. Thank you. Kevin, you should your question.
Okay, thank you very much. Kevin Wilson with the Eastern New Mexico News. I was just waiting for the unmuting to happen. I actually had 2 questions, but I can wait until later if other media members will have questions. So I'll just throw the first one out. Just based on the number of cases that are mentioning gyms, do you believe there's been a significant impact in enforcing mask wearing during exercising?
I don't have direct data on exactly how many people in gyms are wearing masks. I have a little bit of anecdotal evidence in Santa Fe, which is where I'm based. I have not been going to the gym myself because of social distancing, but I have seen in the window there's some mask use. I do not have, a specific answer for the enforcement piece in gyms. I think that anytime you bring people together in an indoor environment, you have increased risk of transmission. And so if gyms are to stay open, as they are currently, they clearly need to enforce mask wearing, good hand hygiene, and cleaning of the equipment after each use. So, I mean, that's the message we would always stress. We would also tell people if they're worried at all at transmission because of their health status, that gyms would be a place where we would not recommend their attendance, and try to get them to get their exercise in another fashion outdoors in areas without other people around.
Thank you. We're going to move on to Patrick Hayes, who has a question.
Yeah, thank you. My name is Patrick. I work at KOB. I had a question about, at the beginning of all of this, we were talking about flattening the curve and not overwhelming our hospitals. Now that those hospitalizations are going down, does that weigh into whether or not we can reopen safely?
Thank you for that question. We actually have quite a bit more material on the gating criteria and opening safely coming up in the presentation. But there isn't a single one thing that we hang our hat on when we make recommendations about reopening. We take a lot of factors into consideration, and they're not just hospitalization, case counts, rates, that sort of thing. It's also the well-being of the population, both from a public health standpoint, an economic standpoint, et cetera. So yes, that is a helpful measure. If our hospitalizations stay down, to be comfortable with reopening, it's not a single piece of data that we use to determine one way or the other. Thank you for the question.
Yeah, and this is David, Patrick. I think too that one of the things that was a great relief to the medical advisory team and epidemiology and everybody was that we had a substantially higher peak over the past 6 weeks, twice as high as the previous one, but the hospitalization rate was lower. And we believe that that doesn't really have that much due to the virus itself, but the fact that seniors in particular have really gotten down, staying at home and not going out and wearing masks and doing all the things they need to do. And so we saw the surge in cases primarily driven in the age group between roughly 20 and 40, with toward the end of that surge, the 20 to 30-year-old age group being the top age group. The younger you are, the less disease, the less serious your disease can be, although we've had deaths in folks between 20 and 25, and we've had people in ventilators, on ventilators in that age group as well. So it's a great relief that the higher case count peak that we saw actually resulted in a lower hospitalization rate. And we will indeed wrap together all these metrics at the end when we talk about the gating criteria and how we're thinking about reopening.
Those were all the questions we have thus far.
All right, well, I'm going to go on and do a little science and media update. This is going to be sort of a tasting menu. I have a lot of slides. I don't want to, I'm not going to read them, not going to go into depth. You'll get copies of them, all of them, like this first one. If you run it in presentation mode and click here, it will take you to the article or the link. And so I think the CDC is getting the word out effectively about a couple things. One is that just because we're flattening the curve again in the United States does not mean it can't get worse or may well not get worse. In the fall, it may indeed, we may see another uptick in cases. Strong emphasis, and I have a little section on vaccines that will answer about a half a dozen questions you all have asked in the past couple of weeks. But step one in the vaccination process for COVID is getting everyone vaccinated for the flu. Last year, only about 50% of Americans got a flu shot. We need that to be higher. We're aiming for 2/3. And then lastly, of course, CDC strongly interacting on or advising around mask use and the fact that if everybody or almost everybody were to wear a mask, we could substantially decrease transmission further. I wanted to stop for a minute and just talk a little bit about behavioral health. Just an hour ago, our behavioral health director, Neil Bowen, Dr. Bowen, was giving a presentation to the behavioral health subcommittee of LHHS here in New Mexico, and he went through this data as well. But this idea that there's a significant increase in behavioral health issues and disorders is a serious idea. It's a serious problem. It is happening in other countries. It's starting to happen here in New Mexico and in the United States as well. But for example, we're seeing an increase nationally and in New Mexico in drug overdoses during the March to May time period. You can see the comparison of January, February versus March, April, and May. And there's not usually seasonal variation in this regard. And so this is a concern, almost a 20% increase. Also, a survey done in late June of US adults reported that 40% of Americans are struggling with either anxiety or depressive symptoms, trauma or stress-related symptoms, increased substance use or starting to use substances to cope, and consideration of suicide at an 11%, which is probably 10 times higher than you would normally see in a population. And so, and then interestingly as well, that we seem to be seeing these more alarming increases in these statistics in younger adults, people of color, those who are working through the pandemic, and then those who are at home, not paid, taking care of family members who are either older or have serious illnesses. But this is something we'd like your help in getting the word out, and we have our number to call in. And I think another, one of the things people say was, well, why is this even happening? And I found this article useful. I'm not going to spend a lot of time on it again, but basically they point out that every time one person passes from a COVID-19 disease, there's an average of 9 people who are bereaved or depressed. And I've certainly noticed an anecdotal increase in the number of people I know that have someone in their family who's had COVID, and the number of people who have somebody in their family who's had COVID and died. We had one of my wife's more distant relatives, but still in our family, 55-year-old man contracted COVID-19 and died from it. And so this also can explain that bereavement as part of the depressive symptoms and anxiety symptoms. Our crisis line is available 24/7, and also there's a national move to have a new crisis line instead of 911, 988, and you'll be hearing more about that from us in the coming months as well. But it's sort of a national suicide and behavioral health hotline that can connect people to resources more quickly. We also have an app that people can use to, if they feel comfortable calling, texting, accessing resources. One other interesting fact I gleaned from Dr. Bowen's presentation this morning before I had to sign off was that it turns out that now that we're using telemedicine, that people are a little bit more open and willing to share about their issues than they are in person, which I found fascinating. I would not, as a clinician, I would, I probably overvalue that face-to-face contact, and it was very interesting to hear that as well. I want to spend a little bit of time on some great work.
Hey, David, can I interrupt you because we have a question related to the suicide data that you are presenting? Okay, give me just one moment. All right, go ahead. You should be able to ask the question.
Yes, Dr. Scrase, this is TJ Wilhelm from KOAT. And quickly, you talked about the suicide data. Do you have any data that shows amongst teenagers in New Mexico that suicides have gone up? And then my second question is, could the mental health issues be because those teenagers may be staying at home?
Thanks, TJ. Good to hear your voice again. I do not have that data on teen suicide. There can be a lag due to the medical examiner reports. All those cases, I believe, are referred to medical examiners. So I don't have contemporaneous data, although I believe you're totally on the right track. You know, the teenage years are a time of individuation, separating yourself from your parents, developing your own worldview. They're a time of heavy dependence on peers and people outside your family to create a sense of identity and who you are as a person in the world. And so I think that we are seeing an uptick, certainly in this age group of young adults and teenagers, and that it, in all likelihood, is certainly related to the issue you raise. I think it's important. It's ironic in a way because I think our teens are the most connected, or have the potential to be the most connected to their friends electronically. And as a parent of a teenager, we're working really hard to encourage our son to reach out and connect in those ways as well, because we know that, well, my wife and I think we're great company. Our teenage, all of us who have teenage kids know that that's not necessarily the case. So something to keep an eye out. If you have teenagers, to let your readers and viewers know, is something that we all ought to be looking at. And Alex is going to make a note about seeing if we do have any trended data yet for this year on teen suicide. I don't know, Chad, that's not your division, but whether you have any info on that or not.
Thank you, Dr. Scrase.
Yeah, I don't have anything further. Thank you.
Thank you.
I think I'll go ahead and move on. I wanted to thank the people at All the lab has been an amazing partner. They have enormous computers that can do a lot of complicated calculations, and they've been really helpful to us in the school modeling, which, as you can imagine, is very complicated and requires a lot of data crunching to come up with issues. The team there, headed up by Kirsten McCabe, and these are people I've been working with that are just great. Sarah Duvall, Paul Fenimore, Judith Morant, Benjamin McMahon, Patrick Worley, and Carrie Anna Minora. And just doing great work for us. They pulled together a little bit of a briefing on COVID in kids. And again, I'm not going to read the slides, but they just really looked at all the world's literature on what do we know about disease in children. And the reason they took a look at this is that there's a lot of mythology about children and COVID. At the very beginning, it was, well, we had no idea. In April and May, it was, well, children don't even transmit COVID. And in June and July, we realized that no one was actually testing kids very much, and that might be the reason. And so the conclusions they reached are a couple. And one is that the kids transmit just like adults do. There's one study that shows that that might be a little higher transmission in the 10 to 19 age group than the under 10 group. But we also know that severe disease can occur in children, and while children normally have mild disease, there can be very serious illnesses in infants. And it's just a reminder that we don't know what the long-term effects of a COVID infection are just yet. And so having an infection like that in childhood could cause serious complications in adults. We know about neurologic deficits, blood vessel deficits, cardiac deficits, and we just don't know enough about what those outcomes might be. And then lastly, their conclusion was, particularly in reference to schools, but just if we are going to be reopening schools, and as in childcare and other settings, really have to be tight on infection control and consequences, and making sure that we're rapidly intervening if there's a case in a classroom, or rapidly intervening in a childcare center, like we actually do right now in New Mexico. They point out that most of the reported cases in children have occurred very recently, and they don't think that's due to some change in the virus, but it's more due to the fact that we're doing more testing in children. There's good evidence that if you live with a child in your household, that you're likely, just as likely to get COVID, or more likely if you don't have any smaller kids in the home. And there's no real clear evidence that kids have lower infection rates. And I wonder, because New Mexico has tended to be on the higher side of children's infections, whether that's due to our aggressive testing policy and offering that to kids. I'm going to just show one or two slides. One, because I could absolutely not resist sharing a slide with you that had the term mosh pit on it. You've heard about summer camps in Georgia, in Oregon, and Missouri, including one where kids were dancing in a mosh pit during the day without masks. And so no one should be surprised in these kind of settings to find out that COVID spreads. And so we know that it spreads in kids. This was an early decision in New Mexico, maybe not that early, but in May, when we decided not to allow summer camps this year, because we just knew that the level of congregation, the level of closeness, and the difficulty of getting teens and peer groups to wear masks could be a risk, and other states have proven us right on that. So just some information on children. There's one in here from the Washington Post on how to take care of your mask. It's a good thing to remind people that you ought to be washing these things, and you ought to be, don't hang them on the mirror where they can dry out in the sunlight and maybe be damaged, and be sure to throw out those masks when they start looking and smelling badly. We like to be frugal, but we want the mask to be safe. That's the purpose of wearing them. I purposely passed up the 10 slides that we put together on the gator controversy, just because I don't think it's worth a slide. Here's another one that I think is a great window into the American psyche. Here we have NCAA sports. Some leagues, following the lead of most professional sports, or some professional sports anyway, and withholding fall sports. I'm a Big Ten fan, went to University of Michigan 3 times. I'm proud of them, and the Pac-12 for deciding to postpone. But then we've got other conferences who are just planning on playing. And so, like I said earlier about younger kids, we know that 70% of people with COVID on MRI studies, at least in one study, have lesions in their heart, and they're inflammatory lesions, which are called myocarditis, which just means inflammation of the heart muscle. But in those situations, doctors recommend 3 to 6 months of rest. So exposing young athletes to the first part of a season and infections, this is, now we may be treading into my personal opinion, but I really feel like we could do better as a country with a national strategy on some of these things, because I know professional athletes, many have chosen not to be exposed, and I think our college age kids might deserve a year off, understanding that their whole career has been focused perhaps on this year. And so that's just a little bit on kids. Depression, we already answered a few questions. In sports, anything there, Alex, before we go to the next section on vaccines?
No questions. I don't see any. Why don't you go ahead, David, and yeah.
I'm just correcting my spelling of the word vaccine. I do know how to spell vaccine here. And so, so a lot of interest in vaccines. The Department of Health has been planning this for months already. That phase 1 is flu vaccine and phase 2 is the COVID vaccine. It's interesting as we evolve. We've told you there are over 100 vaccines in development. Some have 1 dose, some have 2. The products aren't necessarily interchangeable, and there's different requirements for the vaccines. There's some vaccines that are going to require storage at -70 to -90 degrees, and there are almost no healthcare facilities in the country that currently can do it. So there's obviously some problem solving there. Some vaccines can be used in kids or not. Uncertainty about pregnant women. All the vaccines are going to likely require, except the ones that are synthetic, some sort of socially distanced and PPE-laden vaccination practices. And so there's just a lot of variables here. It's kind of like modeling, too many things going on at once. And so, and also we have lower vaccine rates in some groups that traditionally have stayed away from vaccines. Sorry, what I should have said is we have some high-risk groups for COVID that traditionally have stayed away from getting vaccines, which creates sort of a dilemma that we're going to need to solve as well. Just a reminder, when we think of a vaccine, we think about the center arrow here about getting the shot, but there's a lot of steps that have to happen beforehand, including prioritizing populations. Nobody's going to be surprised that the initial people to get the vaccine will likely be healthcare workers and vulnerable elders. But then distribution channel will be complicated. Administration we all know about, but then there's an awful lot of scientific follow-up and record keeping that we need to do as well. And so just as you're reporting this news, stepping back to this 50,000 foot view and understanding that administration is one piece in a much bigger puzzle is important. And then lastly, you've been asking for time frames, and this is from a CDC conference that we attended this week. You can see that these time frames, there may be some limited doses available as we finish up phase 3 trials in America from October through December. Imagining or hoping that a large volume of vaccine gets on the market in the first quarter of 2021, as we talked about. This line is sort of illustrative, but I think depending on demand, which I hope is high and I hope is sustained, we can keep this production up and get to the point where we have a sufficient percent of our population, 60, 70% of people vaccinated. And if you want to talk about reopening, the big reopening that we all are looking forward to doesn't occur until we get the majority of our population vaccinated. So that's kind of the timetable. I wanted to lay those out there. I'll give you, you'll have these slides. You can click on them. I think the whole CDC presentation is publicly available. You may want to refer to that. But I think, and this is where you all come in, that engaging the community with targeted messages that are fit and speak to different cultural groups is going to be the key to the vaccine effort. Without efficient, effective, and persuasive communication, I think we won't succeed in getting most of us vaccinated, which will delay even further our ability to go back to most of what we enjoy doing in real life and most of the things we did before the pandemic hit. And I think that is my last slide on vaccines. I don't know if we have any questions today on that. I know that answers a lot of questions you all asked before.
No questions, David.
All right, let's keep going. I mean, you're not forfeiting your chance to ask questions on these topics. You can ask at the end. Another set of slides that I'm going to run through. The MAT, as I've told you, has been studying multiple different issues related to testing, rapid antigen testing, rapid molecular testing, 2 types of rapid tests, pooling, serology, saliva. And so that full report will be available by tomorrow on the MAT website. But I just was going to take you through a real high level, and even a high level of the high level. So there are a couple, 3 antigen tests that have been approved. They usually use a swab for this, a nasal swab. 2 are on the market already, and the third one is not just yet. Like rapid antibody testing, these tests tend to be more sensitive to people early in their disease and who are getting sick with COVID and have symptoms. But we need to figure out how we define those populations and have a plan to get the reagents we need. I'll say at the end, but we need to have a plan to get the reagents we need for our existing tests. Having additional reagent-dependent tests doesn't guarantee that we'll be able to do any more tests, because we really need the reagents, the chemicals, the probes and primers that we need to run the tests. Rapid molecular testing, Abbott ID Now, that Matt originally thought had too low of a sensitivity. Further research shows that if you use the test exclusively on symptomatic people earlier in their disease, in the first week of symptoms, they are as effective as the PCR tests. But again, you have to use it on symptomatic people. And so I know some of our labs are looking at how do we start re-implementing those machines that we do have in the state, but making sure we're not using them on an asymptomatic population. Pooling is where we take specimens from 4 or 5 different individuals, combine them into a single test, run that test. If it's negative, then we know that all 5 tests are negative, and so obviously that decreases the amount of reagent and testing supplies we need. It's not by 80%. It turns out it's by 45% in a 5 specimen pool strategy. But nonetheless, it's a way of saving bench machine resources and reagents. We think we could do about 1,300 more tests a day through TriCore if we were to develop this pooling capacity. So they've already run some trials. The problem here is we need emergency use authorization, EUA, from the Food and Drug Administration. And so that's being worked on now, but there could be a delay in that as well. Serology, these are those little paper strip tests sometimes. Sometimes they're blood tests, the things that you can do to see if you've been infected with COVID. They're mainly for surveillance. And right now there are at least 30 on the market, and none of them have strong evidence that they pick up disease at a reliable rate. So this is more of a wait and see attitude until we get more specific data on each of these tests. What about saliva? This may actually be promising. We do know that other ways of collecting specimen, for example, a provider observed self-collection nasal swab, which is happening in some drug stores around the state, can be used. Home testing, we're not anywhere close to being there yet. And saliva testing, we're doing a validation test for that to get that okayed. But we think that the good news is we may be able to do more of that, which will cut down on our need for PPE and swabs and things like that. But we still need good, reliability data to move forward. The last real strategy is that we really need to figure out a way to take this data that we do have and already on some of these tests, and take the machines that we do have, which on the lab-based testing, which is the most reliable testing, and develop a more reliable supply chain for those materials they need. We talk about that at almost every press conference. You know, there's the reagents, there's the swabs. Now it's what we call disposables, pipette tips, although we got 38,000 of those earlier this week, thanks to some work the governor did on our behalf. And so that's kind of the update on where we are with different ways of testing to not only keep where we are now, but increase our testing. Any questions on that, Alex, before we get to the sort of home stretch?
No questions, David.
All right. You know, these are other ways of presenting the data. Dr. Smelser already presented it in a really excellent way. We've got that. These curves you're used to now with, again, a growing percentage of people under 20. I've got some data for those of you who like just kids, 0 to 17. I'll show that in a minute. And with our 20 to 29-year-old age group at the forefront now, highest group in terms of COVID disease. Still well above our target for testing. It has dropped some. There's some insurance coverage issues, which should not nationwide, shouldn't be a problem. In New Mexico, we've also had some reagent shortages and equipment shortages, but we're above where we need to be and hoping to maintain that. And while our case count has come down, our test positivity rate has dropped as well, and we're doing extremely well. Best in the West, as Dr. Smelser mentioned, top 5 in the US. This is all of COVID from the inception of the pandemic, hot in the Northwest over the entire course, but now the Southeast, as Dr. Smelser mentioned, getting darker and darker in color. And you can see here just in the past week that the real hotspots outside of Bernalillo County are much more in this southwestern region of the state. Child data, we're missing a column here, but this goes from roughly mid-May to last week. And you can see the percent of total cases in children now, 0 to 17, has gone from about 10.7 to 12.2%. More testing in that group, but I think the rest of the country is catching up to where New Mexico has been for a while in terms of recognizing that there is more disease in kids. We continue to maintain our sort of stable, but higher than it used to be, level of mobility here. We're running 8 weeks now, and I think that mobility holding steady, people staying at home, wearing their masks is a lot of what's contributing to our success here in New Mexico with our declining cases. This just breaks down that same mobility curve by regions of the state, with the Northwest actually being higher, and the areas with urban centers, central and southeast with Las Cruces, maintaining a lower level of mobility. Our theory on that is because people don't have to travel as far to get what they need if living in an urban area. I just wanted to briefly touch on this. It was a little bit of news the past couple days. Some of you noticed that if you did your own math on the press release case counts and did a rolling 7-day average, the number was lower than what we show on the on the gating criteria website. And there are 2 ways we do the calculation. One is off the press releases, the daily confirmed cases. That's the most timely, but when you get a case report this afternoon from Dr. Smelser, it tells you the number of cases. That will consist of people who were tested yesterday, the day before that, sometimes going back as long as 1 or 2 weeks. We do well with lab turnaround time in New Mexico, running under 72 hours for testing right now. But for modeling purposes, if we trace and put the test back to the date that the specimen was collected, it gives us a better idea of spread and the slope of the curve. And so we've been doing that. Ideally, we use it in modeling. And so because we wait until the test results are back in, we build a lag time in. And so Alex has put together a table here that can show you what this basically shows simply is if we go by test date, like we do on the gating criteria website, you'll get one set of numbers. If you go by report date, like you get in the press releases, you get a potentially different set of daily numbers. But the main point is they both add up to exactly the same number. This one is just a little lagged. And these are the graphs that go with this. So this is the press release data. Sorry, this is collection date data. So the gating criteria website with its 6-day lag, most recently 132. And this is the confirmed daily cases without a lag at 133. And you can see that going back, we actually ended up with a lower number on the 14th than we did with just the confirmed daily cases as we got more lab data in. So that's just a brief touch on that. This is the same epi curves Dr. Smelser showed you, and this is the positive case by date of specimen collection. Just wanted to highlight that's what we've been showing you. So anything on that, just any last loose ends to clear up before we finish up with gating criteria today, and we will have time for questions.
I just got a question. Yes, we do. Just give me a second, David. They're just coming in now.
So this question is coming in as more like the daily case count report than the date of specimen collection. So it is more timely.
Dr. Scrase, this is TJ Wilham from KOAT again. On the 7-day daily count, do we have the most latest number today of what it is using the criteria of the test date that you just clarified for us?
Yeah, we update that, TJ, Monday, Wednesday, and Friday. It's a great question. So, but remember, there's a lag. So this is the most, I believe, Alex, you can confirm this, the most recent update is as of the last date, we believe we have complete data, the 14th. That number officially is 132. And
so,
go ahead.
Sorry, I didn't mean to interrupt you, Dr. Scrase. So by looking at that, would it be wrong if we were to say that we may have met the gating criteria on the one that mentions the 7-day average being, I believe, at 168? Have we met that at this point?
Yes, we have. And that's a great lead into our next topic, which is the gating criteria. So here we are, green bars all around all 8 measures. You have absolutely no idea how gratifying this is to Dr. Smelser and I, and you have no idea how grateful we are to the people of New Mexico, because there's not a single one of these measures that isn't heavily influenced by the behavior of folks in New Mexico, whether it's spread rate by masking and social distancing and staying at home, along with the case count, whether it's testing capacity by getting tested and seeking testing when you're symptomatic, the contact tracing, answering the phone, answering questions, and then of course hospital numbers are fed, as you asked about earlier, by all these other numbers. And so, yep, we're official. We have met the gating criteria. I know what your next question is, but hold that for 1 minute. People, another question we got last week was, so where did you get the 168? Like, where exactly does that number come from? And we had a long discussion. We looked at all over the United States, the world actually, at different benchmarks. This is a brief table of them. As you know, we ended up at 168. Couple examples are the COVID exit strategy, and I think that'll be my next slide. I'll show you. The cutoff from red to yellow is 80 cases per million. We have 2.1 million people, so 80 cases per million is the same as 168 cases here in New Mexico. California uses a county watch, and New Mexico has a county watch as well, using this 8 cases, so per 100,000 population. There are other metrics. Harvard had one at 10 cases. The modeling team lean toward the left side of this curve and a more conservative approach, but I think the governor's final decision was 8. We believe at 168 cases a day, and if we can sustain that 168 cases a day, we believe that we have room to do a little bit more reopening, and I want to emphasize a little bit, and that's going to be my closing point. So here, this yellow curve, we turned yellow this week, and that's because the new cases per million per day dropped below 80 here. It was 75, again, 80 cases per million is 100, in New Mexico is 168 cases per day. And so, and everything else is green. You might want to know, well, when do we finally get to be green? Then that would have to get, we'd have to get to 40 cases per million per day, which is half of 168. So that'd be 84 cases. The county watch I mentioned, this takes 2 of those variables, the cases per 100,000 in a county and the test positivity rate. And if you're off target on both of those, you become red. Some of you are aware that that influences whether or not nursing homes can allow visitation. And we're not allowing visitation in counties where right now that are in this red zone. The one thing I think I've learned more than anything else in the pandemic is that where you are determines how you're going to do in any kind of reopening effort. And so that ambient level of cases and the adequacy of your testing have far more to do with how many additional cases you're going to get, because you'll get them when you reopen, than anything else. So we have met the gating criteria. We need to move slowly. I believe that for a wide variety of reasons, in around Memorial Day weekend, when we last met our gating criteria, the people of New Mexico thought it was time to turn on this on-off switch. And then we had another, we got up to twice as many cases, over 325 cases a day, which was a very significant strain on our system, our Department of Health, on our delivery system. And so what we're saying is we need to move the rheostat up a little bit. We need to make a little bit of room. We can't let up at all on masking, staying 6 feet apart. You know, in the greater scheme of reopening, the discontinuation of masks is not something that probably is ever going to happen until we're all vaccinated and COVID is a thing of the past. But we do believe there is some more room. I know you want to ask how long it has to be that way, and to preempt that question, I think I'm just going to ask Chad for his epidemiology opinion. Like, is 15 minutes with all the gating criteria positive? Is that good enough? Is it a week? Is it 2 weeks? Is it 6 months? I mean, from an epidemiologic point of view, Chad, what do you think?
Sure, thank you, David. Yeah, it's a good question, and there honestly isn't a an answer that people know for sure. As we've said over and over again, we're learning from this pandemic as we go. But it's clear that the longer you go meeting all of the gating criteria, the better off you'll be. So we've seen example after example around the United States and in some other countries, but particularly in the Southwest, we've seen Arizona and Texas, who reopened rather quickly when they still had quite a bit of disease in their communities, and they had very big outbreaks. New Mexico has been more conservative, even though we did do some reopening and we saw increased cases. We haven't been hit nearly as bad as the other states, and I think that's largely due to the policies of opening in an incremental fashion. Just in general, I think people understand this. You know, it's not reasonable to make everybody never work, interact with any other person, but that's the only way you're going to get it to go to zero. And of course, as I said, that's not reasonable. So with any kind of reopening, you would expect some upward trending of cases, as long as there isn't other, herd immunity or very high vaccination levels. So in New Mexico, we've chosen to be more conservative in terms of opening slowly and in an incremental fashion. I would recommend we do that. We've seen 2-week delays before case counts start going up, as well as deaths. And so a 14-day might be a good time frame. But for us to stop calling something an outbreak, we usually wait 2 incubation periods, which is 28 days. That's quite a long period of time, which I don't think we'll ever really achieve. But I started it off with this statement and I'll finish it. The longer the better, but we also have to take into more factors than just the public health data. We have to take people's wellness, which includes their outlook on life, their ability to earn a living, et cetera.
Great, Alex. I seem to have lost your Labor Day weekend slide, so I will stop sharing in a minute. I wanted to call our media folks' attention to a Department of Workforce Solutions virtual town hall that Secretary McCanley ran earlier this week. You go to the NMDWS YouTube channel. We think there's a lot of information in there that you all could use for your constituents. I'm going to take down the slides. I will find your Labor Day slide, Alex, or you could send it to me again, and we'll just open it up for general questions.
Thanks, David. So we have several questions. The order I'm going to go is first with Julia Goldberg, second with Patrick Hayes, and third with Scott Weiland. So give me just one moment while I unmute.
Hi, Dr. Scrase, Dr. Smelser, can you hear me?
Yes, we can, Julia, go ahead. I'm guessing this is a math question, but I guess I'll wait and see.
It is a math question. And I've asked it before, and I just need some help reconciling the information I've received. I've asked you previously about the recovered cases, and told you we hear a lot from folks who want to know, well, they want us to only report how many active cases there are, which we're not doing. But you had said previously to me, they can just subtract the recovered cases from the total cases, and those are the active cases. Recently, it seemed as though the recovered cases that we receive every day in our news releases, they're running about 46%. And so the Department of Health Epidemiology via spokesperson said that they're not really up to date due to not having enough staffing to track them, and then also people not necessarily keeping in communication, and that a better way to think about active cases are the hospitalized cases plus the case identified in the past 10 days as an estimate. Anyway, all of that to ask is, I'm wondering what exactly to do with the information that we are receiving every day about recovered cases, which we also can look at daily on the dashboard per county. Should we just ignore it? Is it not accurate? Should it come with a disclaimer? This is not up to date. I would just like some help knowing how to understand that information. That's my first question, but maybe I'll let you.
Why don't you stop there and we'll answer it. Last week when you asked that, I was texting Dr. Smelser for an answer. So the good news is he's here today and can talk to you about the process, case investigators, contact tracers, and monitors, and how that all works.
Great.
Chat.
Sure, Julia, thank you for the question. And your statements earlier about some of the reasons why the recovered cases lag and are not entirely up to date is true. So we could put an asterisk on the website and explain that to folks. That's one consideration. And in terms of estimating the active cases, I think that's where the case counts per day that are out in the press release are helpful. They can tell you what's going on actively in your county communities, as well as the dashboard. And we do have zip code data on the dashboard. So, you can see some of the, the newest cases that are popping up. But the press release is really, really helpful for active cases in the communities currently. So that's one reason we're keeping that up, which takes a significant amount of work, getting that data and making sure it's correct or as accurate as possible, and then putting it out as rapidly as we can. I would just say too about recovery. I mean, the good news is if you look at the case fatality rate, the majority of people, the vast majority of people recover eventually. And so we need to do our best to keep up with that as we can, and we've added staff and some other processes to do that. But people, once they've been sick for quite some time, they get tired of talking to us. So we try to check in with them regularly every few days and see what we can find. But again, that depends on a lot of person power and people responding to us. I would say just in general, I don't want to make it sound like New Mexicans aren't cooperative. They've been very kind and cooperative with us and are interested in helping us with gathering our data. Thank you.
Thank you. Oh, and then my next question, I know that at least some of the folks on the modeling team from LANL have done a lot of work on flu modeling in the past. Do we expect a better flu season because there's been so much masking and other social distancing, or do they know that at this point? I can ask them too, but I thought perhaps you know.
Julie, I'll start and Secretary Scrase can add if you would like. Thank you for that question. We would love to know for sure what's going to happen with flu. That would help us tremendously in our planning. I think the issues you just brought up are absolutely our hope. We hope that the masking, the social distancing, the hand hygiene, the covering of coughs with both mask or hand or whatever, will definitely help us during the flu season. But we can't emphasize enough how important it is for people to get immunized against influenza this year. Clearly, every year we have an epidemic in the state of influenza. Some are worse than others, but 50% coverage rate for vaccine is not enough. We need, I believe we said we're shooting for 2/3, but we're shooting for as high a percentage as we possibly can get. 90% would be unbelievable. It would really help us with our flu season. So please, please, in your messaging to the public, describe to people both to get vaccinated and help them know where they can and how they can get vaccinated. Thank you.
I think the only thing I have to add, Chad, to your question, Julia, is that as we look at models for going back to school, the ones that seem feasible right now are a slow start with less children, and any school situation where you have a lower density of kids and like alternating days and things like that. Whatever it does for COVID, it will do for influenza in all likelihood as well. And so that's a great observation, and we may see that across the board. I think to Dr. Smelser's point also, while the influenza vaccine doesn't cover every type of influenza, I think if I get a respiratory illness in the fall, I don't want my doctor to spend a lot of extra time sorting out whether it's COVID or influenza. They'll run those tests anyways, but we can actually make diagnostic accuracy of COVID symptoms higher by having more people vaccinated as well. So that's my clinical point of view on that one. Thanks. Alex, I think you said Pat Hayes was next.
Yeah, that's right. So I'm going to turn over to Patrick so that I will unmute him and he can ask all your question. Patrick, I think you need to unmute your device to ask your question.
Okay. Can you hear me okay?
Yes.
All right. So yesterday, APS announced plans to keep schools online through the fall semester. And then given the current numbers in our state, do you think this is the right move? And are you guys also paying attention to what's happening at other colleges around the country, not just, locally, because we've seen some outbreaks in some of the big name schools back east?
Yeah, I will lead off and then I'll let Dr. Smelser clean up on this one. I have a really close friend at UNC. He's a oncologist there and ran their internal medicine residency program many years. And so we've been corresponding about this back and forth over the past couple of days. I think we are paying really close attention to what's happening in other states, particularly with respect to K through 12 school reopening. And one thing I will say without going into a lot of detail is if you look at the experiences in Georgia, Alabama, Mississippi, Oklahoma, Indiana, if they had our gating criteria that we are using here in New Mexico, they would not have reopened schools. And so my opinion there is just that the ambient case count that they had in their states was so high that it was perfectly predictable that they were going to have serious problems and start quarantining massive number of kids, you know, in the first week or two of school. With respect to colleges, I know that our higher ed department is working closely with schools. I think in college you add this added highly labeled variable of not having parents around. And so kids are away from home for the first time and they've been cooped up in their house for 6 months. And, you know, I mean, if you just step back for a minute and ask yourself, what's the chance they're all going to get together for a big party on the first day of school? I don't know. I'd say it's probably pretty high. And that's exactly what we saw. And so I know our leaders here in New Mexico are looking closely at these situations, and it's a tough situation to figure out public policy that manages adolescent behavior, given what we know about the development of the human brain, and that the risk-taking behavior centers of the brain in the back here kind of get well developed at age 14 and 15 and 16, and the rational parts of our brain that kind of keep us out of trouble and help us consider the pros and cons of situations don't evolve until their 20s. And so I'm not exactly sure how we get a public policy that could effectively manage that, but maybe Dr. Smelser has some ideas.
Thank you, Secretary Scrase. You know, I don't know if it's really an addition, but to echo some of what Dr. Scrase said, you know, it's a reasonable decision until you know that the prevalence or the amount of viral burden in your area is very low. And as I said before, you need to know that for over an extended period of time. So we don't want to harm kids. We want kids to be able to learn. We want families to have their children go to school and be able to work. That's the goal for all of us. As a father of 2 children who are currently at home, I'd love for them to be back in school. I love my kids, but I would also enjoy for them to be in school and learning and not being, you know, cooped up at home. But I think we have to take it into a larger context, have the prevalence, so the amount of virus circulating in our communities to be low and remain low over time, to be, you know, safe. As I said before, anytime you open in any which way, you are going to have more cases until we reach a point where there's actual herd immunity and enough people out there that are protected from the virus. So with any reopening, we'll see more cases, is my standard prediction. The other thing I'll add is that we aren't in a vacuum, and Secretary Scrase mentioned this as well, but we can learn from what's going on in the other states and the other jurisdictions when they do some reopening of both colleges and high schools, et cetera, and see what's happened before we make our own decision. That's just wise practice. You might as well learn from others that are going before you so that you can make the best decision for New Mexico. Thank you.
Okay, next I'm going to switch the order a little bit to prioritize a chance for some media folks who've not yet asked a question to ask. So I'm going to turn over to Scott Weiland, then Chris McKee, then Dan McKay, followed by Michael McDevitt. And so Scott, I'm going to unmute you now.
All right, can you hear me?
Yes.
Yes.
Okay, I think this might have been briefly touched on before, but I was just wondering, I was looking at, you know, New York Times tracker, which might be somewhat in line with yours or not, but in any case, it seems like enough in line to ask. Showing that, okay, that Santa Fe cases per 1,000 are 6, and that's a bit higher than neighboring counties in the north. So why isn't Santa Fe County's rate falling as much as, say, like Bernalillo, San Juan, Sandoval, Valencia? It's staying a little bit higher.
Which rate do you mean?
Per 1,000, per 100,000 cases per
100,000. Okay.
So right now it's 6, roughly.
Yeah, if I understand the question, why is it staying a bit higher
The
than
rate, yeah,
surrounding
why is the
counties?
rate, why is the infection rate staying a little bit higher here?
I'm not, we probably don't know exactly, but a general consensus among groups that are in epidemiology that are looking at this is that, Santa Fe is a regional center, so we attract people from the surrounding areas that come in. So we might be getting some spread from other areas that way. But the other thing is it's a tourist destination, and so we do have a significant amount of tourists coming in, which also could influence our rates for sure. But I don't think I have an exact pinpoint answer for you. Thank you.
Thank
Yeah,
you. Next. Oh, go ahead. Go ahead, Scott.
Yeah, I was just kind of going on the like the fall, wondering if there was, is there anything that can be done to prevent another rise in cases this fall? And if it comes, what does it look like, and okay, what happens then? You
So,
get that
I'll
wave
start.
that everyone's talking about.
Yeah, I'll start with that. I think there's a ton that can be done to prevent another rise in cases. The first thing is not to turn the on switch on, but to just lift the dimmer up a little bit. If people still should stay at home, should still wear a mask every time they go out of the house, shouldn't go into indoor spaces outside their own homes where people are unmasked. Staying 6 feet away from people, keeping surfaces and hands clean at all times. Those things really actually work. And so, I think we need New Mexico, like it's a trade-off. If we want to reopen a little bit more, get kids back in school or do other things, we have to be super diligent. In the counties where mask use is 50% or 40%, they need to get up to 90%. They just do. And so as far as what another peak will look like, I tend to think if it's going to look, I hope we don't have one, because it's a tremendous hardship on businesses to reopen some and then have to go backwards. It'll be awful for schools to start sending students back to class and then having to close down classrooms and schools if we have another increase. It's hard on DOH and their deployment of people for testing and contact tracing and all the role. So I think the path from here to a vaccinated world is us learning to balance those two forces, learning to stick with what we know works, and in all things, do them in moderation. And you're going to go out when you really, really need to, but don't plan the big family barbecue with 30 people on Labor Day. Chad, anything else?
I think that one of the things that folks on the media can really do to help us get to a place to reopen in an incremental fashion the fastest is to continue to hammer home that people need to maintain a 6 foot distance between each other. They need to minimize the number of person-to-person interactions to as low as possible, wear a mask when they're out in public, and all of the other COVID safe practices that we've talked about. And we don't obviously have the entire state on this call, but we have significant coverage from the media and others, and please get that message out over and over again. Thank you.
Thank you. Next, we're going to turn over to Dan McKay so he can ask his question. Go ahead, Dan.
Hi, thank you for taking my question. Do you anticipate New Mexico making any changes to its public health order or its other health regulations before August 28th? And I'll mute myself and you can answer. Thank you.
So David here, and I think that most of the discussion that's going on right now is how long do we need to see this stable trend? So I'm adding 28 minus 20 is 8 days from now. So I'm not anticipating a big change between now and then. Most of the discussion and focus of our efforts is on school, rerunning that model, figuring out the safest alternative. You know that we got 330,000 kids in New Mexico who potentially could return to school. So that's a very big group and what seems to be a big priority right now. But, you know, discussions are ongoing. The governor has the ability to do those things. I think one thing I've learned is we won't necessarily reopen in the reverse order of how we close because we have a lot more information, such as the data on contact tracing that Dr. Smelser showed you to let us know what are higher risk activities. And so, in any case, I think we're looking for a little bit longer period of than that, but I know that John Bingaman is working with the Economic Recovery Council. I was with them yesterday sharing some data with them. I know they're working on options as well. And so a lot of activity, a lot of planning, a lot of trying to understand what we can do to have a little bit more freedom without the increased risk we experienced so profoundly last time.
Thank you. Next, I'm going to turn over to Chris McKee.
Hey there. Thank you. Thanks very much for taking the question. I just had two. One of them is in context to schools and a little bit kind of like what Patrick asked earlier. I wanted to ask, again, kind of in a slightly different way though, in context to APS's decision last night to go to all virtual learning through this semester, would you encourage all other school districts to do that for the first semester online? Is there a method of schooling at this point that you'd like to see all schools in New Mexico go to, even though APS's decision is obviously singular? And then my second question was just about the southeast part of the state to ask you really how big of an issue or concern is the case count in the southeast right now again? Is it to a point, I guess, where you guys are extremely alarmed or whatnot? I'm just trying to get a kind of a gauge about sort of what we're seeing in the southeast right now and really how alarming is it? Thanks.
Thank you very much. Those are both great questions. I'm going to take the first one and then I'll turn it over to Dr. Smelser to talk about the southeast. I think that when we have done the modeling with the help of Los Alamos, it's very, very clear that having everybody stay home and do distance learning is the option that is least likely to increase the number of cases. You're not having human-to-human interaction. And so if all you were doing was, all you cared about was the case count, yeah, you'd probably do telelearning until everyone's vaccinated. However, there's a lot of data that shows that kids don't learn as well at home with telelearning as they do in a classroom. We don't have the technology infrastructure in New Mexico to guarantee every student the kind of internet access that they would need to pull that off in their homes. We can get them on iPad or another device, but you know, we still have a lot of work on the broadband infrastructure in the state to do it. There are other benefits to school around socialization. So there's that whole component. There's also a teacher component. Teachers' comfort with returning to the classroom. Teachers who are older, and New Mexico has some of the older, you know, I don't want to say it that way. The average age of teachers in New Mexico, I think, is in the highest 3 or 4 in the country. And with that being the case, that means we have more teachers with age as a risk factor for COVID infection. And so there are issues there. I think one other thing that we haven't brought up much is that all school options will have some telelearning, because there will be parents and teachers who say, you know, I'm not comfortable with in-classroom learning. And so all the school districts are going to have to be ready to provide that kind of education. Lots of schools are doing both, where, you know, you've got the classroom is running and they're planning on having children in it, but then they're also having folks on their iPad or whatever observing classes. So my field is geriatrics, so I'm not the right person to comment on how all those factors weigh for together for kids in K through 12. But I am persuaded by Secretary Stewart and other people who are very conversant on these subjects that all distance learning sacrifices a number of important issues related to socialization, quality of learning, amount of material learned. And so I am not one of those people who backs an all distance learning approach, because I think there are other factors. And so I hope that effectively answers your question. If you're asking behind the scenes, because I'm conservative, I'm always looking at the medical aspects. Am I trying to keep this all telelearning? The answer is no, I'm not at all. And Chad, how about the Southeast? How concerned are you?
Sure, I'd just like to add, I mean, I don't think an online only for option forever is a good idea either. I think we need to get kids back in the classroom as soon as we possibly can, just to do it safely. And I do thank the scientists and researchers at LANL who are helping with the modeling. It provides one of the pieces of information needed for us to make wise decisions. But again, really the prevalence of the virus in your communities is the key to school reopening. In my opinion, it needs to be low. In terms of the Southeast, we're concerned. I mean, that's our area of the state that the trend hasn't been the same as others in terms of it going down. It's been plateaued. You asked about case counts. There are less people there, a little bit lower testing levels to some degree, so there are less cases. We're not surprised about that, but the rates are, significant, and they're above our threshold, as you saw in the maps. And so, and we also know that part of the state, as I mentioned before, is heavily influenced by Texas, which is clearly a very large population, and there's a significant disease in Texas. So, yeah, we're concerned, and we want two things. We want every individual with COVID to fully recover and have no, issues, of course. But in those areas that are red, we want those folks to know that they have more activity in their area. They're probably more likely to come in contact with somebody who has the disease, and we want them to take as many precautions as they can to stay as safe as possible. And then for the rest of the state, any place that has higher rates and higher case counts, we need to know about that so that folks don't travel there, and that we can minimize spread through other parts of the state. So yes, we're concerned about the Southeast, and we'll stay concerned until we see, significant drops in the rates and the numbers of cases there. Thank you.
Thank you both.
Thank you. We have our one final question for Michael McDevitt, and I'm going to unmute him so that he can share it.
Hi, Dr. Scrase and Dr. Smelser. This is kind of piggybacking off of what Dan said. I guess after August 28th, I know that there's discussions about how long we want to be meeting these gating criteria, but do you anticipate any sort of relaxation in the public health order as a result of meeting the gating criteria as soon as after August 28th? And how do we anticipate making sure that cases don't rise too much with the next reopenings, so that we don't end up in this situation again where things have to shut down further?
Thanks. Again, I know that's the question of the hour. My honest answer is I don't know. I know August 28th is a date because that's when the current public health order expires. I know there are groups of people that I'm not a part of right now that are working on options and alternatives. I also know that we will, if the plan gets carried forward to open K through 5, I believe it was, or 5 or 6, 2 days a week after Labor Day, that will result in increased cases. So there's, if that plan rolls out, then that is going to take up some of the room we've created. In the meantime, if New Mexicans want to do what they need to do to drive those numbers even lower, that creates more room and more opportunities for reopening. So all my involvement has been really focused on schools and the discussion and debate and spirited debate about schools and what we need to be ready for that. And but what I can do is I'll circle back with John Bingaman today and see if he has any other ideas. And then just lastly, what can we do to keep that surge from happening? It's that same old stuff: masks, stay home, go outside your home, anywhere, indoors or outdoors, wear a mask. Simple, distance from other people, and keeping your hands, surfaces clean, but mainly staying home, avoiding those interactions. We've discovered a whole new world in our family of driving up to the curb and getting bags of groceries and other things we order from local businesses because we want to support them. Food, we're experts at drive up food, procurement as well. And so there's lots of ways to support local business and still stay safe. And we consider ourselves a research lab here at the Scrase Tarrant household for finding all those ways to do that.
If I could quickly follow up, I know that those are the public health guidelines that have been reiterated by you guys since March and April even. So I guess while those are proven things to work, what further, these are the same types of guidelines that were advocated in June when these reopening. So I don't want to slight those obviously, but I mean, is there anything further that we can say to people to prevent a similar spike when reopenings happen, in addition to those obvious guidelines, which I know have been, if that makes sense.
So you remind me of a little joke. I think it was Jon Stewart said he was looking back to see if we had any clues from the 1918 Spanish influenza pandemic, because he wanted to contrast the strategies we have now with the ones we had back then. And back then they were masks, social distancing, and staying at home. And so some of those basic things haven't changed. My answer to your question is we need more people to do it. Find a way to get the 40 to 60% of people in some of these counties who aren't wearing masks, who are out and about, who are, interacting in large groups and posting pictures on Facebook. Find a way to convince them that they can make a big difference, because we can if we go from, if we can increase mask use, for example, by up to 90%, that in and of itself creates an additional room for safe reopening. So it sounds quirky. It sounds overly simplistic. I know you'd love if we could be more creative and come up with something a little bit snazzier that we all could do that would be the magic bullet. But the fact is those things work, and those are the tools we have right now. Now, for example, if we had treatment or, immediately wiped out the virus, or a pill that healthcare workers could take once a day before they went to work that would prevent them from getting it. I mean, those are another set of strategies that we could employ as well, but we just don't have those. We don't have evidence, really, contrary to what appears to be 90% of what's on the internet that people send me a link to in my email. We don't have good, solid evidence that any of those things work. So until we do have a treatment option, or until we're all vaccinated, we're going to have to just get more and more people to do what we know works now.
Thank you, Dr. Scrase.
Great. Well, we really appreciate your time, your attention, your great questions. We'll circle back on those ones we couldn't answer. We're appreciative of your attention, and please let your readers and all know that that they can really still thank them for what they've done already, and let them know they can continue to make a difference. Alex tells me that we'll get that Labor Day slide out to you. It's a great infographic that gets almost cut and paste right into your op-ed, into your editor, the feature you'll do on television, or the editorial that your editors will write about the importance of a safe Labor Day weekend and its connection to return to school and further reopening of the economy. And with that, we'll say goodbye and thanks again.
Thank you very much.